We'll begin with Claire Mowbray, Manual Handling Advisor and RGN, working for Hillingdon Hospital's NHS Foundation Trust. Claire has worked in the field of manual handling since 1994 and obtained an MSc in back care management with distinction from Loughborough University in 2006. Claire has held positions within the National Back Exchange, including National Secretary and Professional Development Officer, and is the current chairman of the Oxford Region Group of the National Back Exchange.
Hello, thank you for inviting me. I work at Hillingdon Hospital in northwest London. It's a district general hospital. You can see from the photograph in the middle, it's an old 1960s tower block, and we've got an annex corridor at the back of the hospital where we've got old style Nightingale wards. The picture on the left of the screen shows the lack of space we have in the hospital. You can see porters trying to get a standard size bed through doorways. We don't have automated doors, and some of the bariatric beds don't go into our side rooms. They don't go into some corridors, for example, the accident and emergency corridor. We've also had quite a high turnover of staff because of the pandemic and because we're a London hospital. The photograph on the right-hand side shows a cohort of international nurses. Like a lot of hospitals, we've done a big international recruitment. The photograph on the right, the nurses in that cohort were mainly from India. You can see from the picture, some of them are really petite. They only weigh 45 to 50 kilos. So we have a greater duty of care to protect them. Also, they're used to manual lifting in teams. So the challenge for them has been getting used to our equipment. And when they're under pressure, as is human nature, we tend to go back to our standard customer and practice. So that has been a challenge for them. So those have been the challenges for us. If I look at perhaps some of the solutions, I felt we needed to go back to basics. For me and my colleague in the picture, Gerard, it was working alongside staff on wards, helping people to put good techniques into practice, getting familiar with the bariatric equipment. And I strongly feel that plus size patients shouldn't be treated any differently than any other patient. It's about basic nursing care, how we talk to patients, how we treat them, finding out what their goals are, having accurate treatment plans. And for us as an acute hospital, discharge arrangements begin on admission. For example, we're finding out what their previous function was, and we're aiming to restore that wherever possible. So, for example, we had recently a learning disability patient who'd come in from a care home. We'd found out via occupational therapy that that patient was hoisted out of bed and into a specific chair. So we knew that we were aiming to get the patient medically fit so they could sit out of bed, and then we would be looking at discharge. We also looked at our risk assessments. Previously, our risk assessment form was in the nursing admission pack. The difficulty with that is only nurses referred to it. So I've introduced and am piloting in 3 wards from January this year, a multidisciplinary patient moving and handling risk assessment plan. And unfortunately, we're still on paper medical records. We haven't yet moved to computerized records. The Cerner system is going to be introduced in November this year. So I just want to take you through a case study of a particular patient. So this is our moving and handling multidisciplinary risk assessment form. I've chopped it up. It's just one standard A4 size sheet with a continuation sheet. This patient was admitted to an acute respiratory care ward. She was acutely ill, very breathless. You can see from the top of the form, I've anonymized it. I've taken out the dates just to maintain patient confidentiality. But this patient was 190 kilograms on admission, and she was 160 centimeters in height. She was high risk because she needed multiple team members, specialist equipment, and she was in bed, non-weight bearing because she was so acutely ill. On the left-hand side of the form, you can see the assessment on admission. So she was assessed by a nurse, and the admitting nurse assessed that it took 8 staff to roll this particular patient, and she was nursed on our trust-owned Barros bed and a Sapphire air mattress. Initially, it was taking 8 staff to roll and 6 staff to slide up the bed using wide single patient use slide sheets. The right-hand column is the review, the first review of the patient. Unfortunately, 2 nurses injured themselves moving this particular patient, and the patient was referred to me. I would have liked to have had the referral before the injuries, but that is the current situation. So when I assessed the patient, I ordered a Barry 10A acute Medstrom bed, and I also ordered a turn care mattress. And we programmed the mattress initially just to do a quarter turn because that's all the patient could tolerate. That took the number of staff down to 3 staff. And I also ordered a gantry hoist. And initially it was a full body sling, a hammock sling that was being used to transfer the patient from bed to chair. And that was being used by nursing and therapy staff. And you can see that it took initially 4 staff to actually hoist this patient. The next part of the form includes any other tasks that are required. So this particular patient needed to go for scans, and the ward needed to borrow a hover mat from another ward because she was over the weight limit of our lateral transfer board. So the admitting nurse signed it, and then I signed the review. Moving further on, and this is where it could be assessed by a physiotherapist or an occupational therapist rather than a nurse. The patient then moved to the rehabilitation stage, and we moved to a rehabilitation bed that goes lower, and we moved the patient out of the side room into a 4-bedded bay and closed one of the bed spaces. Initially, it was just the therapist using the Barry vest or standing harness, but later on in the patient's journey, it was nursing staff, and the patient was eventually discharged to a rehabilitation unit in central London, walking around the bed space independently with a heavy-duty frame. So my summary would be optimise independence, empower patients and their families' carers. Even if a patient is in bed, we can ask them to move their arm across to assist with the roll, teach them how to use the handset, and often we'll use their iPhone to photograph the control panel to teach them and teach their family, partners, carers. So our aim is to restore patients to their previous function, and sometimes we even improve it. It's not me doing 12-hour shifts on the wards. I would like to thank the multidisciplinary teams at Hillingdon and Mount Vernon Hospital who never give up, acting as the advocate for patients and their families, despite the challenging times and environment we have faced over the last few years. I would particularly like to credit Khadija and Helena, 2 ward managers, Vivian, occupational therapist, and Wendy, our lead respiratory nurse physio. Truly inspirational. Thank you very much for listening to me.